A very good afternoon and a warm welcome to one and all who have joined us for today's webinar entitled My Journey as an ABR Survivor, Lessons Learned. Myself, Dr. Kiranjit Kaur, and I am the moderator for this session. This webinar is being hosted as part of the Erasmus Plus funded project entitled Prevent It, wherein it stands for antibiotic resistance. The key aim of this project is to create awareness on antibiotic resistance among healthcare professionals, students, community, journal public, so that all of us can start fighting together today itself for the upcoming future pandemic. So as part of this project, we have already conducted 9 webinars very successfully. And today it is the 10th webinar, which is being taken care by Ms. Vanessa Carter, our speaker of the day. And on the bottom of the screen, you can see the logos of other universities who are part of this project as well. Next slide, please. During the last webinar, we had got a chance to listen to Mr. Himanshu Sharma, who was an ABR survivor from tuberculosis disease. And today we have Ms. Vanessa Carter, who is not only the survivor, but the fighter who is acting as an active healthcare professional, as well as she is putting a lot of contributions to fight against this disease so that the other people should not go through and should not face the circumstances from which she has gone through. And just now have a look on the objectives of this webinar. As I've already told you that today you will have a privilege and a chance to listen to the fighter herself. So after going through webinar, you will be able to understand the journey of Miss Vanessa Carter, how she fought against the bad bacteria. You will be able to understand the role of an e-patient fighter in this healthcare related complications. Also, you will get an insight about the advocacy in the sense that how and what actions you should take as a healthcare professional to combat these resistant infections. Just a quick detail about the webinar. This webinar is being conducted on Zoom and it is being streamed live on YouTube. Obviously, whenever we listen to any speaker, we have questions in our mind. So don't worry, you have a chance to speak your mind and to ask whatever comes to your mind during the presentation. So please use the chat box, which will be available on the right side or at the bottom of your YouTube screen. And you can use the hashtag AskPrevented to type in your questions. And we will, depending on the time availability, we will try to take as many questions as possible. And in case you missed the chance to listen to the YouTube webinar today and you want to share the same information with your friends, family, and colleagues, please, you can visit the YouTube channel, obviously, and the same uploaded and recorded version of the video will be available on the Prevented website, Facebook, Twitter, and LinkedIn accounts. Next slide, please. Now let me introduce to all of you the speaker of the day, Miss Vanessa Carter. As you can see her very cute photograph on the extreme right of the screens, she is a very charming personality, and trust me, when I was going through her CV, I was really mesmerized by the challenges she has faced in her life, keeping that cute smile on her face. And when I went through her CV, I could find out that she has not constricted herself to one domain. She is working into multiple directions and still she is rocking in all the fields. So just for the audience, I have tried to pen down few of her achievements as the time did not allow me to go through all the things. So if you can just change the slide and I can go through your achievements. Yeah, thank you. So just to add few, she is an antibiotic resistance and One Health activist, and she is also working as an e-patient scholar. She is a founder of HCS MSA. SA stands for South Africa, and the overall thing is known as Healthcare Communications and Social Media South Africa. As a part-time, she is also working as a dissemination officer within the communication department at the Common Health Pharmacist Association. Not only this, she provides digital skills development training for the effective use of social media. And she has won the Women of Year Directors Award in 2015. Recently, in 2018, she has also received the Tropics Magazine Top 200 African Changemakers Award as a leader woman. So without wasting a time, I would request Ms. Vanessa Carter to kindly share her screen and share with us her fruitful journey. Over to you, Ms. Carter.
Thank you very, very much for such a wonderful welcome. And good afternoon, everybody. So thank you for having me. It's a real pleasure to be with all of you and to share my experiences. So my presentation today is, as mentioned, it is focusing on a whole lot of aspects in terms of antimicrobial resistance. But of course, because I'm a patient advocate, the main focus will be on that. So my title is, where do e-patients fit into the antimicrobial resistance puzzle? So thank you again for all that, going through that kind introduction. I always say my main role in all of this, I've got different titles, I work with different organizations, but my main role in this is as a patient advocate for antimicrobial resistance. I'm also a civil society champion at the Africa CDC. And a patient reviewer for the British Medical Journal. Find DX Voices for Diagnosis award winner, and a certified World Health Organization infodemic manager, which I will get to towards the end. I'll give you a little bit of insight how that fits into the work that I've been doing in health communications and social media. So there are two sides to me. It starts with my story as a patient, and it ends with the advocacy that I've been doing for the last couple of years. So let me start with my story, and that spanned over a period of about 9 years, between 2004 to 2013. So this was the last photo that I am always so proud of. I was 25 years old. I called it the last photo because it wasn't shortly after this that I had a terrible car accident. And there was just so much, as you can see by the car. This took place in Johannesburg. What happened was we were driving, I was a passenger in the car, and the car overtook us. We lost control. We spun around and we ended up hitting into a concrete wall, quite badly. So you'll see on the right-hand side, that was a passenger seat where I had to be dragged out of the back door, put on the side of the road, and I was resuscitated at the time. And I had very, very bad injuries. So I was taken to the Johannesburg Academic Hospital, and actually working with the Wits University. I was put into high care, given a 30% chance of survival because of the injuries. And I remember waking up on the Tuesday. It was basically 3 days after having the accident, not knowing what had happened, and thinking to myself, where am I? And I was on a ventilator. I could hear the ventilators going on around me. I could hear the heart machines going on around me. And it was a very, very traumatic experience. So this was the list of the injuries, starting with the head injury and the facial fractures. I had a broken nose, broken jaw, smashed right maxillary sinus, orbital blowout. I lost the right eye, and I had severe facial laceration. So it was a massive head injury. I haven't listed the actual brain trauma that I had to deal with, hitting my head. I'd actually hit my head on the dashboard because the car didn't have any airbags. And then, of course, the major abdominal injury, which caused a lot of internal bleeding. And this was the first thing that they actually performed surgery on, because it was so life-threatening. And actually, it ended up resulting in a repeat laparotomy 8 years later because of the adhesions that I had, developed inside of my abdominal area. So I ended up getting an adhesive bowel obstruction then about 8 years later. I also had a fractured pelvis. I had a neck injury. I had massive whiplash because of obviously the impact on my neck and on my head. And then I had a severe back injury as well. So the bottom photo, I should actually swap these photos around. The bottom photo was before my accident. One of the last photos I took at 25. The two top ones are me at my mom's house recovering. I had my own house at that time, but I couldn't go back to it because I needed caregiving. I needed somebody to look after me for simple things like getting in a shower, getting in a bath, and of course massive headaches, and I couldn't walk because I had the fractured pelvis and I had the stomach injuries to get through. It took me about a year to get past this stage, and to finally get myself back to work and to finally figure out how I was going to fix the damage, which at that point in time, after a year, was the face, was to try and get myself to a point where I could take off the iPad, take off the coverings, and start feeling normal again. The other thing that I also did was a medical legal trial, because in South Africa, when you have a car accident, we have a fund called the Road Accident Fund, which I needed to go through as well, to try and get some financial support to perform the surgeries that I needed to actually do. So my facial surgeries was, when I talk about the 9 years, it was from 2004 to 2013. As I say, figuring out the steps of what had to be done, because one of the biggest things about a facial reconstruction is that you need different types of super specialists working very closely together. It's a very sophisticated part of our bodies, so teamwork is very important. So these were the initial injuries. This was the first scan that I had, not very sophisticated technology about 16 years ago, but it was good enough to see what they needed, what they had to work with. So this was actually what was done at the Joburg Public Hospital. But there was still a lot of work to go on from there. So on the left-hand side, you can see that there's already a prosthetic implanted. It was a silicone implant that was put in the orbital. It was called an ocular implant, to basically give the socket some volume. And then on the left-hand side was a plate to try keep the bone structure together. And you can see towards the nasal bone, towards the septum, there was just a lot of repair that needed to be done because the bone was completely obliterated in that area. So I relied on prosthetics, a lot of prosthetics to be implanted from different specialists to be able to look normal again. So from the first surgery that I had, which was obviously the ocular implant, I then had a second prosthetic implanted called a med-pore orbital floor, which was done by an ophthalmic plastic surgeon. And then in my 6th year, I needed my 4th prosthetic. My 3rd prosthetic was actually the artificial eye, which was an external prosthetic that they were working on. The 4th prosthetic was an alloplastic implant. Obviously, the left-hand side is just an illustration. It's not really, what they did to me. But I had, if you look at the gray area, that was done on one side of my face. So a maxillofacial surgeon performed this in 2010. And it basically was to try and bridge that gap, which I demonstrated in the last 3D scan, so that the bone didn't keep, there was no more pressure on the bone, which what was happening at the time was it was kept moving down. So I kept losing volume. And after that, we had to do a follow-up plastic surgery with a microsurgeon, because the alloplastic implant was inserted a little bit too high, and where the surgical incision was, it started adhering to the alloplastic implant. So we did this very simple plastic surgery with a plastic surgeon, and to release the adhesions. And I carried on about life. After the surgery, it wasn't a huge one. I wasn't in a lot of pain. But I went to the store one day and I came out and I thought, I felt this moisture on my face. And I got into my car, ready to go home, and I pulled down the rearview mirror and I saw this. I saw this fluid coming out of my face, seeping down, almost like tearing out of my face. And I just panicked. I didn't know what was going on. I mean, I've had 3 prosthetics implanted before this. And the brown eye, I know I've got a blue eye now, but the brown eye was the external prosthetic eye. And I didn't know what to do. So I phoned my plastic surgeon's office and I said, where do I go? Where should I take medicine for this? And he said, they said, go to the emergency ward and we'll meet you there. It's probably an infection. And from this day onwards, for the next 11 months, I was basically in and out of surgery, doing what they call debridement surgery. So it was basically trying to get the infection off of the prosthetic, plus reconstructive surgeries like cheek rotation flaps is one of the surgeries, plastic surgeries that I had. And what that is to try and reconstruct the damaged tissue that had been eaten away by this bacteria, which at the time I didn't know it was bacteria. I just knew it as an infection. And so what was also happening was I was still under the care of different doctors. So we would do the one surgery, and 2 weeks later, to try get rid of this tearing of pus coming out of my face, 2 weeks later, I would get the infection back again after surgery. And then we would go for another plastic surgery. And 2 weeks later, the infection would come back again. And then I would go back to, the doctor, maxillofacial surgeon and the plastic surgeon, and say, what do I do? And then they would say, okay, maybe it's coming from your nasal, maybe from your sinuses, because you had very damaged sinuses from the accident. And then I would go see an ENT surgeon, ear, nose, and throat specialist, and he would do a sinus drainage, to try clear the infection, and then the infection would come back again. So this went on for, seeing different surgeons, doing different surgeries for 11 months, getting different opinions, and on top of it, getting prescribed antibiotics between them during not only the consultation of having to manage the infection, but also at the time of the surgeries. So it was, it as I said, went on for about 11 months. So this was one of my surgeries. This was a cheek rotation flap to show how they were cutting away at the eyelid to try and get rid of the infection, plus do the debridements. As I say, for 11 months it went on like that, until eventually I call this my point of no return, because I hardly had any tissue left. That they'd cut away so much, and thank goodness I hadn't got rid of the eyelid itself, because that is very, very difficult to reconstruct. So in my 11th month, what happened was, when I went for like my second ENT surgery, when they were draining the sinuses, by then my plastic surgeon and I had built up a good relationship. In fact, I always tell people it was a friendship, because he was just so accommodating. He would see me anytime. And he said to me, Vanessa, I know you're getting differing opinions from different doctors to manage this infection, but I'm going to be honest with you. You need to take that implant, that alloplastic implant, out, because if you don't, you run the risk of it infecting your other prosthetics, or it could turn fatal. And this was the first time I was actually hearing these words. And, I was listening to these other doctors. And anyway, I went into surgery to go do sinus drainage, and he was working in the same hospital. So it was very easy for him to come into the theatre during my ENT surgery and to take the prosthetic out, because he said, if I see the infection on there, I'm going to take it out. And when I woke up from the surgery, from the anesthetic, the ENT surgeon was sitting at the end of my bed, and he said, Doctor, the plastic surgeon took the prosthetic out. And this rang alarm bells, because I thought, first of all, my face completely collapsed, because now it wasn't just the tissue damage, it was also this prosthetic that was, sort of configuring the bone structure underneath that was removed. And I was worse than the day of the accident. I was really looking bad. There's no ways I could walk out like this into the public. And of course, you can see the eyelid is hanging. It's even more exposed to the bacteria and everything. So I didn't know what I was going to do. But But alarm bells rang when that happened, because my plastic surgeon, first of all, didn't have my permission to take this alloplastic implant out. And I thought, what is going on? So I phoned the pathologist offices and I asked for a copy of the test, and it came back as MRSA, methicillin resistant Staphylococcus aureus. And antibiotic resistance, I started Googling it on the internet, and I learned about that. And I also learned about how the overprescribing of these particular antibiotics could worsen this type of infection that I had, among other things. So it rang alarm bells, and I thought, wow, why didn't anybody explain this to me? So again, I went back to Dr. Google, because at this point in time, my doctors had lost hope. They didn't think that they could fix my face. It was now very, 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 very specialized, very complicated. And then, of course, I had the risk of redeveloping the infection that I had. So we couldn't do multiple surgeries. We had to get it right. In the first time that we did it, or the second time that we did it, to try and avoid me losing my face completely, or it becoming fatal. So like I mentioned, I had a medical legal trial at the time, and during that medical legal trial, the attorneys had put together about 50 medical reports, and of course I had access to my history in the hospitals of what had been done, and I had a photo history. So I took all of that and I put it into about 4 pages, between a Word document and a PDF, to try and easily show what my journey had been. And I got on Google and I started searching for the best doctors in the world that I could find, because I knew we couldn't make mistakes. And I was very, very fortunate that I ended up finding a doctor called Dr. Edward J. Catterson, who was working in the face transplant team in Boston, at a hospital called Brigham and Women's Hospital. And I found him in a medical journal. He had written an article about face transplant surgery, and infection. He was a plastic surgeon, but he also had a subspecialty of craniofacial surgery. So what made him so different, besides the fact that he was working in this very advanced unit in Boston, was that he was working with both the soft tissue and the bone. So he could give me sort of more of a holistic explanation of what I needed to do, whereas the specialists that I were working with were working in very siloed, so in other words, the plastic surgeon was mainly working on skin, maxillofacial surgeon was mainly working on bone, a craniofacial surgeon works on skin and bone, on the face. So they can, as I say, give more of a holistic opinion of what needs to be done. So Dr. Catterson actually offered me a 30-minute Skype call, which he explained to me what needed to be done, which was a zygomatic osteotomy, which is a medical procedure to cut the bone, the cheekbone on the zygoma, and realign it, and use as little foreign body or foreign prosthetics as possible to achieve this, so that I could avoid infection. So I took his advice, and I started driving around Johannesburg and searching in South Africa online to find doctors that mimicked his advice. And I saw quite a few different professors. I got different opinions again, but I found a professor up the road from me, about 30 kilometers from where I lived, who was quite a renowned facial reconstructive maxillofacial surgeon called Professor Johan Reinecker. And he gave me the exact advice that Dr. Catterson gave me. And so we went ahead with the surgery, the zygomatic osteotomy. And so this is what my face looks like now. You'll see how they cut the bone, where there's that long plate going. So those plates are made out of titanium, which they call the gold standard in healthcare. I've got different substrates in my face. So alloplastic wasn't always the best, because It's a type of plastic substrate. It's not great for, especially in the facial area. So he did the zygomatic osteotomy, put me back together with plates, and redid the orbital floor. He added to the med pore. He did the titanium elevation. And so I call myself an infection prevention nightmare because I have multiple prosthetics. So I always have to be, every day of my life, always have to be so careful with washing my hands and so on, which I only really learned after I became aware of antibiotic resistance. I didn't think about those things until I was empowered with that information. So shortly after we did the zygomatic osteotomy, 2 weeks after again, and just to add as well, we had given it a year between the surgeries that I had, where it was my point of no return to this point, because we didn't want to aggravate the infection. But in fact, I did get an infection back again. And so under the care of Professor Reinecker, we first of all thought that now this infection has moved to the bone, because you can see it looked a lot more aggressive than just the pus tearing down. And so we thought I was going to lose the bone. It's not just going to eat the soft tissue, it's going to eat the bone in my face. So after doing some tests, after doing some diagnostics, we found out that this was not only an infection, but it was also an allergy. So to kind of clarify that, I had become allergic to a topical antibiotic called Chloromex, which is a type of ointment that I was using on the surgical incisions. And so I had to stop using that. And I had also, developed potentially this MRSA infection again. So Professor Reinecker said, right, this is the first thing we're going to do. It was 2 months later, so you can see it was still very aggressive. It was still very red. It wasn't going anywhere. But what he did straight away was he said, right, we're going to start rotating the antibiotics. We're going to go for 2 weeks, but you're going to report back every week to me, and you're going to tell me how your face is looking. And we're going to try and beat this bacterial infection that way. We're going to trick it. So, and of course, I also was taught how to follow infection prevention control very strictly, because I wasn't always in hospital bed. I had to do this for myself. I had to do it at home. When I left my home, I had to be very strict about it. I couldn't touch my face. Your hands had to be clean all the time and sterile. So, and I was also taught very intensely about antibiotic resistance by the professor, so that I could also adhere to my medications very carefully, because some of these medications were, from what I understood, sort of end of the line antibiotics. So I couldn't take 2 in the morning, if I skipped 1 in the afternoon. He would say to me, if you need to take an antibiotic at 5 o'clock in the morning, you set your alarm, you take your antibiotic. Or if it's 3 o'clock in the morning, you take that antibiotic and you go back to sleep. Because if you give that bacteria a 20-minute window before or after the antibiotic is due, you're going to give them the opportunity to mutate, and the resistance will get worse. So I adhered. I understood it, what it was that I needed to do as a patient to participate in managing this intense infection. So this was a few months later. Slowly but surely, things were looking a lot better. And this was then after we got rid of the infection, which probably took about 5 to 6 months in the end. Then I had a rotation flap, which is the skin above my eyebrow that was rotated to build up the damaged tissue. So this was still during my recovery. I looked a bit strange, but basically 2 months after that, and with surgery, everything is about the tissue settling. So it takes a lot of patience. In 2013, this was my final result. So this is kind of an overview. It was a very, very long journey. It was 9 years is not something to take lightly. It's And some of the most difficult things that I found was, like I said, it was communication from doctors, it was siloed care, it was not understanding what it was I had to do, you know, to play an equal role in managing the infection. You know, so something, for example, like you know, should I be boiling water to get rid of the bacteria in it before I clean my face? That was right at the beginning, but towards the end, obviously, from some communication from my doctors and from learning on the internet, I realized that, okay, I need to be very sterile. I need to be sterilizing the counters. I need to be changing this iPad that I'm wearing twice a day and only use sterile iPads. You know, so you know, and to keep my hands clean all the time. For something like a facial injury as well, I was wearing spectacles. I had to sterilize my spectacles, and that kind of communication is kind of lacking, I think, in healthcare. So that was my very long journey, and which ended in 2013, and sort of directly afterwards, because of all these things that really bothered me, I became an advocate. I didn't intend to get to where I am today, but it was just a case of saying, you know what, these were the things that were missing. These were the puzzle pieces. Something needs to be done about it. And so one of the first things that did bug me was, where was the communication about antimicrobial resistance? Why did I not know? Why was it not common knowledge? Why, when I had this terrible infection losing my face, was I still quitting my antibiotics halfway? Because I was ignorant to what it meant. So I was, during the same time that I was going through all these infections, my job was as a graphic designer, I actually, when I was 19 years old, I started a small business, where we did marketing and advertising for small businesses, for clients. I studied graphic design and I studied fine art. And so one of the services that we offered, so at the bottom, you can see some of the work that we used to do for optometrists and the business sector and Electrolux. We had good clients. We were quite busy. And so the top section was where I said, you know what, what's missing is we need more structured information. Why was the internet not very helpful with finding information? And so I created a section in the company where we started marketing medical websites and medical social media. And this was a flyer that we did, and you know, where I was saying, well, you know, for example, antimicrobial resistance is such a difficult concept to explain. What if we could use more visual tools, whether it be a website or whether it be a tablet or something, during a consultation to explain this to a patient, because it made the world of difference in my case. I mean, dealing with what you potentially think is a resistant infection in your bone, you need to be empowered, you need to be educated, and you need whatever tools you can get to become that, so that you can participate. So the other thing that I did was I got into social media, and I started to meet people. I started to network, and one of the people that I networked with invited me to something called a Twitter chat, which took place every week on a Tuesday at 2:30 Eastern Standard Time, which is kind of New York time. And in South Africa, that was like 2:30 a.m. for me, because it was 8:30 p.m. for them. But I got up every week, every Tuesday, 2 o'clock in the morning, I got up, even though I had to take kids to school in the morning, to participate in this Twitter chat and to learn, because what they were doing in this Twitter chat on the hashtag HCLDR, which stands for Healthcare Leader, it was based in the US, obviously, was they were talking about everything I was thinking about. So it was the lack of health communication, not only in AMR, but in all sectors. And of course, they were also talking about digital health, e-health, and how these tools should be used in healthcare. And so participating in that Twitter chat, I got invited to a conference in Paris actually the first time I attended it was in 2014, but then that was only to kind of, see what it was about. I got a personal invite from the organizer, Denise Silver. In 2015, I was invited to present. And in the bottom left-hand side, you can see they had an e-patient program running there in collaboration with Stanford University Medicine X. So all of those people on the left-hand side, except the lady in the center, they are all e-patients. They're all patient advocates, but more European-based and US-based and UK-based. So in 2017, I had through Doctors 2.0, I had kept on applying for an e-patient scholarship program that they were running at Stanford University, and which I was accepted for in 2017. And then I also returned back 2 times to talk about my story to some medical students, and in a third event that they had as well, focusing on where I had focused on antimicrobial resistance. And so what this program does is they've trained about 120 patients around various things. As I say, the e-patient concept, which I'll talk a little bit about now what that is, and also the role of patient participation in medical education, working with medical students to share their stories, and as well as working with in the innovation sector to help co-create innovative solutions. So let's say in my case, that could be a medical website that's directed at patients that is put into less scientific language, for example, that is easier to find and maybe a little bit more visual. But of course, the objective is to include as many patients as possible, working together with medical researchers and innovation companies. So after that, I also developed my own Twitter chat. I mentioned that I'd got into the healthcare leader Twitter chat in 2013, and that encouraged me, inspired me to do one for South Africa, which I moderated for about 4 years. Approached different charities, and I'd also worked with the Africa CDC and the World Health Organization and the One Health Tripartite, which happened last year, to moderate it on their behalf. So what happens during these Twitter chats is we record the data on an analytics platform called Simpler. And you can, when you set out a certain amount of questions, you can get feedback from the attendees to see what their experiences were. So it's kind of in a sense, it's like co-creating or what they call design thinking. So I'll show you quickly here. This is what the transcript looks like. So when we arrange this chat, we gather this data, we gather this insight. And it's a lot easier, to do this in 1 hour than it is to bring together people in a room, if they want to discuss what the gaps are, for example, in the patient experience for antimicrobial resistance. So the other thing I've done as part of my advocacy, after learning, at Doctors 2.0 and Stanford, and using my own experience, I developed an e-patient course in South Africa, which was accredited by the South African Medical Association. And I've also provided capacity building to various stakeholders, including patient groups, civil society organizations, healthcare professionals, and medical researchers, because I found the more I spoke about this, the more I realized that there was a gap in them using various digital media channels to reach patients and the public. And I think one of the biggest reasons for that is because it's not, they weren't taught to. When I went to Wits University last year to give some capacity building to the public health researchers, they said, well, we don't really know where to begin with creating a Twitter profile, for example, and what is it that we need to disseminate, and how do we use hashtags? So there is, as I say, like there is that gap between patients are wanting information, patients are wanting to, use these social channels and the internet to access information, but on the other hand, there's that problem of how do we do it? How do we reach patients? How do we give them information? So this is something that I really think needs to be improved, and taught to medical students from the day that they enter universities. So this was also part of what we were taught at Stanford, was all around patient and public involvement and engagement. And as I mentioned, co-creating. So at the top, you'll see the course, one of the courses that Stanford University Medicine X developed, where we took it, and it was all about how we as patients can work with medical researchers to develop not only the research articles, but also innovative solutions. So at the bottom, I've given an example of a research project that I have personally contributed towards with the Africa CDC, where I helped them. I gave input about developing a survey which would go out to civil society organizations working in antimicrobial resistance in Africa. So here's another example of what's happening in other countries. I currently live in the UK. I've moved here recently. So this is a program that the NHS runs to promote the involvement of patients in the innovative process of trying to establish exactly what is it that they want? What type of information are we looking for? What type of solutions do we need? So this is actually, if you want to research it a little bit further, besides the patient-public involvement and engagement, it's what we also call human-centered and user-centered design principles, where you can also look up design thinking. So what is an e-patient? So the internet, as you know, was first made publicly available in 1991. And it's expanded really, really rapidly. One day we were using Google, and as you know, the next day everything's moving to Facebook, and the next day it's moving to TikTok. And so the web has been developing in what we call phases. So web version 1 was your kind of Google. Web version 2 has been your social media. And what they call user-generated content. So it's a platform where you can generate your own content. And moving towards 3.0, web version 3.0 is more like your connected platforms, so community platforms where they have their own communities on them, or they might be connected to a wearable device, for example, that you use, that they can link back into that platform. And obviously it keeps on developing. So we're trying to move now towards web version 4.0, the fourth industrial revolution, and so on. So the internet is not going away. But how e-patients fit into that is, back in the 90s, before the internet was made publicly available, as you know, patients would go to the doctor, and it would be very one-sided. We would never walk in there with a pile of papers and say, hang on, I researched this and I think that I might have this problem. But patients are doing that now. They're going online, they're researching their health condition, and it's not always a good thing, but sometimes, depending on how they access information and evaluate it, it can be useful to medicine. So as I mentioned here, the digital revolution has changed and is still changing medicine and the way patients are seeking information and managing their health. So I've put a little sentence at the bottom there that goes back to participation, because I often get this question: how do we involve patients in the medical research programs? And I think that if you put yourself into patients' shoes, not all patients, I've been very lucky that I've been able to fly all over the world and so on. But, sometimes digital technologies are helpful for that sort of thing, because you might be lying in bed. I've been in ICUs a few times. I've been bedbound a few times. And sometimes those sort of technologies make it possible for patient participation, and so it's important that we try to understand how we can use them for patient and public involvement. So before the term e-patient, really sort of emerged, the term cyberchondriac was coined. And because the use of the internet was a very new thing to everybody. And what that basically means is, if you look at this picture, I've looked at my symptoms on Google, and I think I have got 8,346 life-threatening diseases. And I think most doctors would relate to that, because sometimes you find things on the internet that are very frightening. And so that's why it's also important that, when we talk about it in e-patient circles, it's important to use the internet, but at the same time to use that information to go back to your doctor and to be directed by them, because at the end of the day, it works they work together. Working with doctors and working with finding information works together. We as patients are not doctors, but we need to learn. We need to have access to good information to be able to be good in e-patient. So cyberchondriac was kept in the dictionary, and it was derived from 2 words, which was cyber and hypochondriac. So shortly after that term was developed, when the internet was released, was a researcher called Dr. Tom Ferguson, who started doing research about this, because in his mind, he thought, this can't be all a bad thing. There has to be some pros to having patients have access to information. And so he started working on research in a white paper to study these new digital patients, and he coined the term e-patient. So he was an early advocate for patient empowerment. In the 70s, he was urging patients to assume control of their own health and believed that the internet and other digital technologies could be a way to do that after it first appeared in medicine. So this is the white paper, which you can visit the website participatorymedicine.org/e-patients white paper to go and read a little bit more about what it was that he wrote, and which later on became a group of scholars working together to actually finish this research. So it's been reported that there are 10 different E's. And when I talk about the 10 different E's, they are the goals. They're not, just because somebody goes onto the internet doesn't make them a good e-patient. The goals are to create empowered, engaged, equal, emancipated, educated, evaluating, expert, enabled, equipped, and electronic patients. Those are the 10 goals of the E's. And so whatever innovation is designed or communication is designed, these are the goals that you want to try and achieve. Electronic might not always be one of them, because we don't have to always talk about it being digital information, but I'll get to that in a second. So let me run through different examples of the E's. Okay, so as an example, when we talk about the engaged patient, how can we build solutions to get better engagement? So in other words, is it a good idea to, if the technologies aren't available, then yes, but if they are available, is it a good idea just to write a research article that's 50 pages long and say, here's your learning, here's how you can learn about your medical condition? Because in some cases, there are health literacy gaps, and there are other literacy gaps. So perhaps something like virtual reality is a good way to go in the future, where it's more immersive and where it's more engaging, and where patients are able to learn more easily through visual tools, visual aids. So evaluating, and this kind of, the evaluating patient, this kind of goes back to the cyberchondriac message of, how evaluating on you, when you find misinformation or disinformation, are you being a good e-patient to evaluate using things? For example, reviews aren't the greatest way to go, but it is one way to go. Are you looking at the reviews that are being written about that particular article? Are you going to fact-checking websites, to evaluate the information that you are finding? So again, that's one of the E's, and this is the goal, that we need to try and, that patients need to get to, in order to be good e-patients. So I just want to go back to the slide here, because Dr. Ferguson's vision was that e-patients are hunters and gatherers of information and data, and that they could also be an asset to the health system, not a burden. So when you think of an e-patient, don't just think of them using the internet to find information, because we know that the internet is not perfect for healthcare. It needs a lot of work, and that's what we need to be trying to figure out now. But also think about things like your electronic health record or your mobile applications, where that patient is on his own and he needs to capture certain data into that mobile application or into that electronic health record. So, and that's part of being an e-patient. It's part of being an equipped, enabled patient that can participate equally in capturing that information, so that the doctor can see that data, to manage their condition better. So they are, e-patients are actually a asset to the health system. When we start moving to digital health systems, they will be vital to work toward. So here's another E. Emancipated e-patient is somebody that is emancipated. They rely a little bit less on phoning their doctor all the time for frequently asked questions, let's say, for example, that could be available to them on a mobile application. So let's take the picture of the lady, for example. I'm going to put myself in her shoes. As a patient, there were times that I wanted to ask my doctor about how I was supposed to take my antibiotic. I was at one stage on vancomycin, which my pharmacist actually couldn't answer any questions for. So wouldn't it have been amazing if I had been dispensed this vancomycin? The end of the line antibiotic was very expensive, and instead of phoning my doctor's offices, and he was very busy, or going to my pharmacist who couldn't really answer me, that I could see this information on a mobile application that was given to me at the same time that I was dispensed the medication. That would have emancipated me. So as I say, that is an example of what a good e-patient is being given the tools to be able to manage their healthcare condition more independently. So as I said as well, communication has a lot to do with developing good e-patients. On the left-hand side, believe me, I read a lot of, when I first started looking for antibiotic resistance information about it, I read journals. I've got one eye and it killed me, because I battle with the one eye to read. But I did it to learn. But I think in many circumstances, and because antibiotic resistance is such a difficult topic to explain, on the right-hand side, I've put an image of illustrations, visions, ways that we could, tools that we could be using, that the doctor could prescribe. Here's a site that you can go to. There's an app you can download to learn more about antimicrobial resistance or antibiotic resistance before you start your course. And this is what we call patient-centered design, and it can make a difference. Good design improves engagement, education, and empowerment. And again, those are 3 goals and 3 values of what it means to be a good e-patient. So patients can evolve with technology. In other words, if you go to a country, I come from a middle-income country, but we had many places that didn't have good connection. But when you start with the internet, the more you practice, the better you become. So so for example, you might only use Google, you might use social media, Facebook, TikTok, and so on. As I explained earlier, you've got web version 1, web version 2, web version 3. So do you get patient version 1, patient version 2, patient version 3? And that doesn't really have anything to do with e-patients, except for the fact, so if you, patient version 1, you use web version 1 technologies like Google, well. Patient 2.0 is you use social media well. But just because you use social media well doesn't mean that you're an evaluating patient. So there's a very big difference. You can be good at technology, but you might be spreading a lot of misinformation. That doesn't make you a good e-patient. You're just good with using technology. And of course, then it would move on to patient 3.0. So we mustn't be, when we look at patients and say, well, this person uses a mobile application very well, they're a good e-patient. That is untrue. They are a good patient 2.0, but the e-patient, they might not be emancipated, they might not be educated, they might not be equal, and so on. So it's a different thing, and that's important to understand in the e-patient movement. So
I'm sorry to disturb, Miss Vanessa. You are left with 1 minute. If you can just wind up in 1 minute, because we also have to take questions in the end.
Oh, sure. Okay.
Thank you.
I'm just going to end with this. Okay. So finally to end is let's not forget the infodemic. And as I said, information can be very complicated online. So the other thing I'm going to suggest that you do is to look up infodemiology. Infodemic is all about management of misinformation and disinformation, which again falls into the e-patient scope. Infodemiology is a study of the overabundance of medical information, both online and offline. Offline meaning it's still important to communicate AMR in real life to person, to get the results that you're looking for. And of course, traditional media. So for example, on pharmaceutical packaging. And that's me. Thank you.
Thank you very much, Ms. Vanessa. I would request you to stop sharing your screen and put your camera on so that we can have the question answers.
Great.
Perfect. Thank you. A big thank you. I think thank you is a very small word because it becomes very tough to share your painful journey. But like they say, when you start sharing it, it means you have healed enough. So on behalf of all the audience, I am really thankful to you for enlightening us about your journey as well as about e-patient thing. We have got many interesting questions, but looking at the time, I'll just take 3 out of them. So first question is that, like you mentioned, that you have had, many treatments, many surgeries. So at that point of time, you also mentioned that you have your kids with you, you have responsibility of them as well. So how did you manage your, work and your health issues in one go? It must have been difficult, but if you can just share some bit on that.
Yeah, it was extremely difficult.
Mm-hmm.
I was in a relationship at the time, which helped a little bit as well. I wasn't a single mom then. But it was extremely difficult. Because I've actually got 2 kids. I've got an older son that is now 20 in his 20s, and my younger son who's now 12. But it was hard on them as well because they kept seeing mommy in hospital. Recovering from the next surgery. So it was tough.
Yeah. Okay. So in your talk, you have mentioned and you have emphasized more on IPC, right? The infection prevention control, which I also agree with you that whenever as a normal human being, we are going out to a hospital, we don't take any precautions, no, because hospital is a hub of infection. But for that matter, when you were also in the hospital and you were going through different surgeries, so you also mentioned, you were not even aware that whether you have to take a hot water or a cold water, something like this. So what message you would like to give to any individual, because nowadays after COVID, which I think is a positive effect, that at least people are aware about the hand hygiene, which you also mentioned in your talk. But any specific recommendation you would like to give to any person when the person is visiting a hospital, irrespective of whether he is a known person or the relative of a patient, in that context?
Yeah, I think what was missing for me was that I always got very general, very unspecific information from everybody. It was always a case of just keep it clean, or more instructional. So for example, just take your glasses off for surgery, and that was it. And there was never that case of why, keep your glasses off your face. Okay, why must I keep my glasses off? Oh, because there's all these bacteria and germs, which as patients, you know what, you don't think about these things. You don't think about things like being on your cell phone, which most people are when they're lying in a hospital bed because they've got nothing else really to do.
Yes.
Thinking of sterilizing that thing, and how often. So I think that medical professionals should be more specific and give patients more credit in terms of that they could potentially understand things like why it's important to use soap and why it's important to use the alcohol sanitizers and that sort of thing.
Okay, like we talk about the evidence-based teaching nowadays. So it's like, providing the patient the complete information rather than just the simple instructions.
Correct.
That makes more sense, because then patient will also understand why it is important for that patient. Perfect. Another question which one of the student has asked is that in your journey you have had a tough journey. We all agree to that. But do you think that if you would not have faced the problem of ABR, obviously that would have helped you in terms of monitoring time and pain as well? If the infection would not have been drug resistant, then it would have been a little easier journey as compared to the one which you have gone through.
Yes. I mean, if I didn't get a resistant infection, yes. I mean, I spent about 3 years just waking up every day thinking, how bad is my face going to be today? What if it moves? Psychologically and physically, it was extremely difficult. So I mean, well, coupled with the fact that I have a facial difference, that was hard enough to accept. But of course, thinking it's going to get worse was tough. So yeah, definitely. It was the highlight of my journey, and that's why I started advocating about it more than I did about the actual disability. The loss of the eye and the loss of half the face and so on.
Exactly.
Yeah.
Okay. Coming towards the last question of the day, you also mentioned, but again, the question has come that, obviously Google is something which can connect and, interrelate anything with anything. So like you also mentioned 5,000, I don't remember the exact number, that these many symptoms, and nowadays, if you Google anything with your symptoms, the first thing that comes up with, you are having a tumor or you are having a cancer. That kind of thing. So how although you have mentioned a bit, but is there any specific instructions, or do you have any manual or guidelines, or any of your website which provides the information that what could be the exact you have mentioned point 1.0, 2.0 and 3.0, but is there any specific website where one should go, like you were also mentioning about the Twitter talks, 1 hour talks or something like that? So for student, is there any good platform? So rather than going on Google directly, the person should visit that particular website for any suggestions or feedbacks?
There are so many of them. There's so much going on in all of this. I would start with, what's been a good course for me to go on is the Infodemic Manager training course at the World Health Organization. And I would encourage anybody to try and enroll for that. They've actually just opened up for the applications again now. They normally take on about 270 people working in various different backgrounds. So, like communications or epidemiology or so on. And what they teach you is what we need to do to provide more reliable information. Because the thing is, there's always going to be conspiracy theorists out there, and there's always going to, so as healthcare, we need to become more tech savvy, and we need to realize that the internet's always going to be there. So what can we do? And even governments, what can governments do to provide reliable information? That is certified, that the public know, look, this is where I go. If I need to find something, I'm going to ignore. And it's also a case of teaching our kids in school as well about good digital citizenship, how to use the information, how to be cyber safe, and how to identify these things, because we live in the real world. That stuff's never going to go away, but we need to try and counter it. We need to try and counter all that misinformation, and as I say, work towards good, empowered, educated patients that are using these tools.
Yeah, so true. So once again, thank you very much, Ms. Carter, for joining us and for giving us time and sharing your experience. I'm sure, in addition to me, everybody would have learned a lot and gained a lot of information from your talk. So, in the end, any specific information you would like to give to the audience? Anything from your side? Any message?
You know what? Be visible. Don't be an advocate. Be an advocate and be a voice, because it's one thing having all this amazing knowledge and sitting in a room and keeping it to yourself. You have to share it. That's important, and patients are looking for that information. So that's my
Very well
advice.
said. Very well said. Very well said. Thank you so much, Ms. Vanessa. And I would also like to thank my team, especially Dr. Sanjeev K. Singh, who has been a bridge between you and us. And we look forward to meet you in future talks. And stay safe. And thank you once again from on behalf of my team.
You're
Take care.
welcome. Thank you for
Bye
having
bye.
me. Thanks. Bye bye.